Around the World with MS World. I'm Dr. Daniel Kantor here at the Consortium of MS Centers, and I'm joined by Dr. Brian Weinshenker, who's Professor of Neurology at Mayo Clinic, Rochester. Thank you so much for joining us. You'll be giving a talk that has to do with how aggressive we are in multiple sclerosis. Tell me what that means, and how do we make decisions about what kind of treatments we choose for patients?
Hi, Daniel. Yes, well, since 1992, we've now got probably 15 MS disease-modifying treatments that have been approved. And we know that the treatments that were first approved are quite safe. We now have 25 years of experience. And although they have nuisance side effects, serious side effects are quite rare. But some of the more recently approved treatments, although they seem to be more effective, potentially have more serious side effects. And we've seen that with some drugs such as natalizumab, the major complication being progressive multifocal leukoencephalopathy, or PML. But for a number of the other drugs, we know that they have strong effects on the immune system, and we've had them for somewhere between 1 and 10 years, and we don't know about long-term complications. And the question is whether the potential benefits, which, because these drugs seem to be more effective at suppressing the disease, are going to translate into what we want, which are better long-term outcomes.
One of the things we talk about a lot is the risk of the medication. So what about the risk of the disease process itself, the risk of MS?
And certainly MS does have risks, and they're both short-term and long-term. And one of the problems is that the clinical trials that we do mainly look at the short-term benefits and not the long-term benefits. For interferon beta, we now have, I think, reasonably good data, not perfect, that long-term follow-up suggests that disability is less in people that get started on interferon beta early, and not only is disability less, but patients actually live longer. And MS-related causes of death are less frequent. So we have hard data there. Theoretically, a more effective treatment as far as suppressing MRI lesions might have even better long-term outcomes, but we don't quite have the data. And a recent study that was published from UCSF suggests that even when we achieve what we can measure, which is no evidence of disease activity based on no attacks and MRIs, that doesn't always seem to be associated with long-term outcomes. That was published in 2016 in the Annals of Neurology. So it makes sense that very effective suppression of the disease early might have long-term consequences, but it probably has somewhat greater risks, and we don't strictly have the proof that we need that this is going to have the desired effect. So I don't think this means that we should not use these medications. Obviously, we should, particularly in patients that we can profile and think are at high risk for poor outcomes. But should we use them routinely in every patient from the time of the very first symptom? I think that's a difficult issue. Some would argue yes. I might argue it's probably better to be more cautious, but I don't think any of us have exactly the right answer. So we have to continually search for evidence, continually be critical of, not reject, but be critical of hypotheses on which these treatment recommendations to be aggressive early on are based.
And so in the meantime, what that means is every patient is going to go to every single doctor, and they're going to have a different way of practicing. What does that do to patients to not have that uncertainty where they can go and see 3 neurologists and have 3 or 4 different opinions?
Well, I think you're right that we practice somewhat differently, but you know, ideally the information is the information, and we're into a shared decision model as far as, and we have to present the data to patients in as best as we can an unbiased way, where we tell them what we know and what we don't know, what is theory and what is proven, what is, and we have to be honest about potential side effects and the fact that for some things we just don't know whether there will be long-term toxicity. So although we do practice differently, the facts are really the same, and we all present these slightly differently to patients, but I think more or less we should all be giving the same kind of facts to patients and assisting them to make the decision.
Assisting patients to make a decision, a shared decision model, is about as American as you can get. So thank you so much, Dr. Brian Weinshenker, for joining us, and thank you for joining us at home.